to cover. Last we left off with the last PowerPoint, we were just finishing up. We just finished up orotracheal intubation. So the normal way of intubating that we would think of, as opposed to this week, we're going to jump into nasotracheal, talk briefly about that, some other methods of intubation. Really, there's only 80 something slides. So it should be a fairly short night for you guys. I think we've been roughly covering 120 last couple weeks. So I don't mind that. I'm sure you guys don't mind that. Before we get the slideshow pulled up, just because I won't be able to see who's talking or anything like that, does anybody have any questions about anything or operations wise, like any questions about the class or anything that I might be able to answer for you?
Can you hear me, Rudy?
Yeah.
So for the acid-base balances, which one was it? Number 5, the pH was normal.
Yeah.
So that we classify that as normal. You don't have to it doesn't have any kind of fancy name for it.
Nope. Yep. Perfect. Just leave what it is. Yep. Any other questions? All right, we'll go ahead and start sharing. And as always, I like to double check, just make sure you guys can see my slideshow.
Yep.
Perfect. All right. So like I said, last week we ended with regular intubations or tracheal intubations. And then this week we're, even for skills, we're jumping into intubation. So kind of goes hand in hand. Nasotracheal intubation isn't something we're going to use in the field a whole lot, if any, to be honest. A big reason for it is because the patient has to be able to breathe on their own. They just might lack the capacity to manage their own airway. Now, it's totally blind insertion, just as it sounds. It goes through their nose. And you're essentially, I don't want to say a shot in the dark because it does work, but it's more of in a clinical setting. Now, just like an NPA, there's some contraindications to it, like facial fractures, any head trauma. Patient has to be able to breathe on their own, because if they're not able to breathe, if they're not able to inhale, then it's going to be really hard for us to try to pass that tube through their nasal passage. So they have to be able to inhale as we're pushing that tube down. It's good in ideal situations in a clinical setting when maybe, you're not able to perform a regular oral tracheal intubation and you need to find a backup route. Great. For us, we're probably going to end up dropping a different airway, such as a King or an ion gel or an LMA. But when it comes to like totally apneic patients, those patients need to be orotracheal intubated. The only time that I've ever truly seen a nasotracheal intubation is in the ICU. I can't remember what the reason for it was. Maybe the patient had their jaw wired or something like that, and they nasotracheal intubating the patient. It's also good for the simple fact that the patient can't bite down on the tube. But responding to 911 calls, we operate in proficiency. This isn't something we do that often. It's not something we should be proficient in. Should we know what it is, how it's done? Sure. And, that's something that we'll cover in skills, is how to do it. But doing it on live patients can be a whole different animal. And again, if you get to see it done in the clinical setting, pay a little bit of attention to it, because it is kind of neat to watch them do. There's a certain technique where you have to use a bougie and essentially bend your tube in a certain shape to where it wants to follow the nasal passage right down to the trachea. I read something stupid in the book and it kind of upset me, and it was, you can confirm placement by using a laryngoscope to view if it's through the cords. Okay, well, why wouldn't I just orotracheal intubate them at that point? So I'm sure it has its place in the clinical setting. In EMS, again, if you're just responding to 911 calls, it might be a different story. Maybe you're doing critical care transfers or taking somebody from one level of facility to another level of facility. You could potentially see nasotracheal intubated patients, but as far as we're dealing with, it's not going to be common. Again, can be performed on responsive patients. Surgery is going to be another option when they nasotracheal intubate somebody. the mouth doesn't need to be open for you to do it, although having the mouth open isn't a bad thing because you can actually watch the tube go down the back of their throat, just to make sure that you're not going in their stomach. But again, it doesn't have to be. And in the instance, I believe the patient that I had, I believe their jaw was wired shut due to trauma. So that's why they opted to nasotracheal intubate this patient instead of having to perform something such as a cricothyrotomy, either an open or simple. It is a blind technique. There's not a whole lot of intubation techniques that are blind that we just literally insert them blindly, kind of like we would a king or an iGel or something like that. You have a little bit more liability on you, to be honest, because you are hoping that that's in the right position because you're totally isolating the airway. And then you're going to confirm the method like normal means. One of the things that you might read or you might hear a lot of times is that if you see any sort of misting in the tube, that it's an indicator that you've got good placement. That's not entirely true. Anytime you see any sort of misting in the tube or moisture in the tube from the patient when you breathe for them, that could also indicate it's in the stomach. So don't use that as a definitive indicator. My first visualization, my first indicator that I have somebody intubated correctly is watching the cord pass through the tubes, or tube pass through the cords. My bad. My second is making sure that I'm not in the stomach. So I listen over the epigastrum, I listen to my lungs, listen to my left and my right. And my third is me putting on something such as a colorimetric device or ultimately end tidal to where I can get good waveform and really monitor my patient and assess them during transport. The equipment's gonna be very much the same. The only thing that might be a little bit different is you might have to, like I said, use a bougie with these patients because you're trying to preform how you want your endotracheal tube to be placed. A lot of times they'll also use a lot bigger tube, depending on the patient, I should say. The textbook will say slightly smaller, but I'm telling you, in real life, they'll usually use a larger tube. This isn't something that you should be questioned over. You got to think anything that's in the curriculum, not everything is going to be national registry. Not everything is going to be at the national standard. Like you'll see in this PowerPoint, we talk about open cricothyrotomy. So using a surgical cric. Well, in the state of Iowa, paramedics aren't allowed to do a surgical cric. You have to be a critical care or above to perform a surgical cric. But at the national level, you still can do that. So if you get confused, like, well, I don't think we can do that, that's the reason for it. That's why some drugs that you'll go over, that's why the drug list that I gave you doesn't contain like antibiotics and a whole bunch of other medications. They're pretty simple meds. Because those are the ones that they can question you on. The biggest ones that you'll get questioned on during tests are simple meds like dextrose, normal saline, Zofran, simple pain management like morphine, fentanyl, and a lot of our cardiac drugs in terms of like resuscitation. There are some tubes meant just for nasotracheal intubation. They're a little more flexible. They have more of a thinner wall to them, if that makes sense. The plastic housing itself is a little bit thinner, just for the simple fact that if we need to load it onto something or to bend it into a position to where it's going to effectively go down and get us proper placement inside the trachea. Again, it's very similar in equipment. It's the exact same thing, to be honest. You can see here, he doesn't have his preformed. Patient has to be able to inhale. Bevel is always facing the septum, just like we would with a nasopharyngeal or an NPA. Now, you generally want, I wouldn't say back toward the ear. It's almost like a down and towards the ear when you're inserting this, because at that point, it's going to be a lot easier to advance. Kind of like if you put a nasal in and sometimes it's a little bit harder than normal. It's not because they have, a really constricted nasal opening or nasal passage. It could be it was inserted wrong in the beginning. So usually you just swap to the other side. We have what's called digital intubation, and that's very much a blind insertion as well, except you're guiding the ET tube in via feel. I mean, these are patients that, if you think back to when we talked about Mallampati scores, class 1, class 2, class 3, class 4. Class 1 being the easiest airway that we can see on a patient. These people have giant mouths. They open their mouth. You can essentially see their trachea at that point, right? A class 4 is going to be the hardest, or somebody that has severe swelling. Well, digital intubation is only going to work on patients that have a large mouth, and you're able to literally use your fingers to find your anatomical landmarks and then help position the tube down the cords. This is, again, extreme circumstances. I've told you guys from the get-go, I'm not big on putting my fingers in somebody's mouth. I don't agree with it. I like my fingers too much and I really don't want to end up losing them. Reasons why we're not doing digital intubation. Obviously, if the patient's breathing on their own, we're probably not going to intubate them unless we're doing some sort of medication assisted or rapid sequence induction, rapid sequence intubation to where, we're giving, you guys haven't been through meds yet, but a benzo such as like a Versed, or, a hypnotic like ketamine or etomidate. And then we're, following it up with a paralyzing agent to where their body is losing its natural reflexes. They lose their gag reflex as well at that point, and then we are able to intubate them. In patients that they're breathing or patients that are conscious, we really can't do that because as somebody gags, they can essentially slow their heart rate down. And that's what we kind of want to try to avoid. Now, it is very easy to misplace the tube in this because, again, you're doing this blindly, you're doing it off of feel. Well, I can tell you, I've never truly put my fingers in somebody's mouth and felt what their trachea feels like. So, of course, there's going to be a potential for error. When you think digital, you always want to think screen, but think literally your digits, your fingers. Retrograde intubation. This would be if I need to create an opening within my cricothyroid membrane, same place that I would do a cricothyrotomy. And I would essentially use something such as a bougie to hold that opening still. And I could use a scalpel or whatever it would be to create that opening. I would then slide the ET tube over the bougie down into place. The difference is in this instance, we're not shoving the tube down very far at all. It's just to where the balloon is past the opening that we created, and then we can inflate it. So we've essentially bypassed the upper part of the trachea leading up to the mouth, and we've created another opening, which is leading to our ET tube. You're going to hear about this more common in severe cases of trauma, where maybe they can't identify anatomical landmarks for intubation. Again, in the state of Iowa, we're not allowed to use anything to create an opening that it has a sharp edge, such as a scalpel. We can use a needle, or what they call percutaneous, but we can't use a scalpel or any sort of knife to create an opening. That's why we have quick trachs. That's why we have needle crikes. Again, most of the time, you've got trauma, you've got upper airway swelling. This could be due to like anaphylaxis. It could be due to trauma itself. It could be due to some past medical history that the patient has, to where you're just not able to, their anatomy isn't in normal places, or their anatomy might be slightly skewed. Maybe somebody has throat cancer. Maybe somebody that has a stoma in place and the stoma has malfunctioned, and you have to put an ET tube down at that point. Well, that's a little bit different because there's already an opening there, but just some of the out of the norm things that we don't think about. Now, it does take some time. It obviously can cause hypoxia of our patients because it's going to take a lot more time than us performing intubation. I told you guys in the field, I shoot for 30 seconds or less, and that's what I try to train you guys to the level of. Because at that point, we're minimizing oxygen loss, we're minimizing any potential complications. Yeah, there's also some complications with how quickly we do it, if we're doing it correctly. That's why I teach you guys in the beginning, slow is fast, be efficient before you're quick about something. Because if you don't understand how to do it and you're just trying to ram and jam, then it's going to end up not turning out well for you. We also have what's called, I call it ice picking, what they call face-to-face intubation. I've seen this done once actually in the field, where essentially you're looking at the patient. If me and you were to have a conversation, I was sitting straight across from you, you could intubate me in that position. A lot of times this is going to be used during severe traumas like car accidents, where it's going to maybe be a prolonged extrication, getting the person out of the vehicle. And that's what happened in the case that we had. It was somebody stuck in the driver's seat of the vehicle. Very long, prolonged extrication. Partner ended up laying essentially on the hood of the car and doing a face-to-face intubation with them. He used a video laryngoscope, so it was a lot easier to visualize what he was going for. You can do it like you see here, with just laryngoscope and a blade. But again, at that point, it's blind insertion unless you're able to look down their trachea somehow, maybe get above them, whatever it might be. But in these instances, especially with trauma, we're trying to still maintain that stabilized position, that C-spine level. So it's kind of a catch-22. You can't manipulate a whole lot or you're going to affect C-spine, but at the same point, it's almost impossible to intubate like that without manipulating it. So, and I mean, just this simple training, you can do it at your own fire department, your own EMS service, wherever you work. If you guys have an airway head, stick it straight up and down like it's sitting in the chair, and use laryngoscope and see how easy it is to intubate it just facing it. It's pretty difficult. That's why it's something we don't really teach as far as skills wise, because it's something that is out of the norm, out of the ordinary, not something we do very often. But when it needs done, it needs done. What you'll notice about these kind of off the wall skills is that you have to maintain your own proficiency in them. Otherwise, it's not doing you any good. Yeah, innovations, we learned in paramedic school, we do a ton of them. You'll do a ton of them after paramedic school, IOs, IVs, but stuff like this isn't something that comes up very often. So maintaining proficiency through training is pretty important. Now, you will have the times when you fail an intubation. And this could be and failed intubation is described as you went to intubate somebody and at the end, the tube did not end up in its place. That doesn't mean that you attempted and failed. It could be that you were looking and weren't able to see anything and you guys had to stop and you had to pre-oxygenate your patient back up. You had to, provide some breaths to your patient to get their oxygen sat back up before you attempt another intubation. That's considered a failed intubation. Generally, if I fail once, whether I can't see the landmarks or I can't get the tube in the proper positioning, I then turn it over to somebody else to see if they can try it. Or in those, if the patient will maintain. If not, then we go to something like a King or an iGel, our backup. That's why the backup is there. In the instance, we have somebody that's intubated and we have to clear the tube. It's as simple as putting a soft suction down the ET tube. And you might have to, I mean, you could lower it essentially down to the lower level of their lung if needed. You'll see this a lot in patients that have maybe severe cases of CHF. If you've ever heard of flash edema, some of those patients can have like a pink frothy sputum. I think it's what it's described as looking like. In those instances, you can see that start to come back up the ET tube. So anything in the ET tube is bad, right? Liquid wise, because we need the ET tube to breathe for the patient. So something as simple as lowering suction down through the tube. Think back to mnemonic that I talked about, dope, dislodged tube, obstructed tube, pneumothorax or equipment failure. We have to check one of those if our intubated patient starts going downhill. Generally, we try to be as sterile as possible. I get it in the back of an ambulance, we're not very sterile, but just try to keep it as clean as you can. I mean, don't use a dirty, suction catheter that you just dropped on the floor or something like that. Try to be as sterile as possible when doing this. Remember that you are sucking oxygen out of somebody. You're sucking air out of their lungs. So pre-oxygenating, sure, but if the suction is detrimental to your patient's health, like you need to perform it now, you don't have time to do this or that, then that's what you have to do. It's really patient dependent. When we start talking later in paramedic school about stable versus unstable patients, and I won't delay treatment on a stable patient or an unstable patient, even if it hurts them a little bit, like causes pain, but saves their life. I won't delay that treatment just to get pain meds. I can give pain meds after I fix them, but at the time, if time is something I don't have, then I'll perform the procedure and then fix whatever's going on after the fact. I can't think of a time that standing orders wise protocols. I don't know if your protocols have it great. Maybe your CCP service work for a CCP service. Generally, if we have somebody intubated, we're not extubating them. Again, maybe if during a transport things start to go south and you need to change out equipment, or I don't know, you run out of drugs to keep the patient down. I don't know. There's a couple extreme instances, but generally we're not doing any extubations. And you guys get to be a part of these during your like same day surgery and your pre-surgery clinicals. But extubation is nothing more than the opposite of intubation. With intubation, obviously, I'm inserting a tube. With extubation, I'm removing the tube from the patient. Again, I don't know of any protocols to say this, and before I did something, you're probably going to be consulting with a doc on the phone. I mean, telling them what's going on, and if they give you orders, that's a different story. But this isn't something we're doing on our own. That patient was intubated for a reason. So why we're taking away their airway could remain a mystery. I mean, so then there's still that potential for airway compromise. Now there's the potential for them to have spasming of the airway, swelling, whatever it might be due to trauma. It says don't remove tube unless you can reintubate. I wouldn't say that entirely. Don't remove the tube unless you have some sort of plan to manage this patient's airway if things go south. And again, that could be falling back to basic adjuncts such as a King or an LMA. If my patient is truly being ventilated or I'm bagging them or they're on vent, whatever it might be, there'd have to be a pretty extreme reason for me to extubate them. I've never extubated somebody in the field. I mean, yeah, you have a cardiac arrest that you guys end up calling on scene. You're waiting for the medical examiner and maybe you extubate them or something like that. That's a different story potentially, but on a patient that you're assessing that's intubated, we shouldn't be removing the tube unless, again, there's extreme circumstances. In this instance, they're saying explain the procedure to the patient. I'm guessing the patient was in some sort of sedation and started to come to, so they were kind of telling the patient what they're going to do. And you'll actually see that even post-op is they'll let the patients come out of sedation. They want to make sure they can breathe on their own before they remove the tube. They won't remove the tube and then bring them out of sedation. They'll bring them out of sedation, then remove the tube. I would have suction handy, just for the simple fact that these patients are potentially going to vomit. I know I probably would, but they're saying go with the patient's breathing. You know, when the patient exhales, when we should be removing it, not inhaling it. If they're inhaling, we're essentially fighting ourselves then, right? And we're taking air away from the patient. Again, I understand you guys haven't been through pharmacology yet. That's actually the next thing. I think we cover IV access to pharmacology in the next couple weeks. But this is just going to give you a basic overview, not of the drugs themselves, of just maybe some classifications and why we use them in regards to airway management. So if you want to take notes on that, by all means, it might make a little bit more sense when we start to talk about pharmacology a little bit. But our medications are used to, as you can see there, decrease the discomfort of intubation. So we might be putting a patient in some sort of mild sedation, decrease the incident of complications. Okay, so I'm trying to assist myself in making sure that there's no planned complications that I need to deal with. And then make aggressive airway management possible for patients who are unable to cooperate. Again, if I have to sedate this patient, some places will even have protocols for severely agitated patients. They can sedate them and take over their airway at that point. Now, depending on the medication that is used for sedation, generally it is going to be either some sort of opioid or some sort of benzodiazepine, or what we call benzo for short. Medications we use for anxiety. The good thing about that is, we'll just use Versed as an example. Versed has really good amnesic properties. What that means is for the couple minutes leading up to you giving it, they might not remember it when they wake up. Now, if you have a patient, and NTIDL is a great way to tell if patient's starting to wake up out of sedation, because remember, instead of that nice square waveform, we might have like a little hump in the middle of the square called a cleft. That could indicate that our patient is starting to come to. And that can happen 3 to 5 minutes before our patient fully wakes up. So that's a pretty good indicator that I might need to redose my patient with some sedation meds. Now, the only thing I'm concerned about if I give too much medication as far as sedation during intubation is that I drop the patient's blood pressure. I don't care if I take away their respiratory drive. Guess what? That's my goal if I have them intubated, or I'm going to be intubating them. I am entirely worried about dropping their blood pressure because now that's a whole nother thing that I have to manage. On top of airway, now I have to deal with circulation. The big three, ABCs. I'm managing A, I'm managing B. I don't want to have to manage C at the same time.
So I know it's kind of off topic from this, but if you do drop their blood pressure, what would you do? Just start to bolus them?
Yeah, initially, yeah, and see how they respond.
Okay.
Before I went any more aggressive with maybe a pressor or anything like that to raise their blood pressure, yeah, I'm absolutely going to bolus them. And a bolus, a bolus of fluid is a pre-measured amount given just to raise somebody's blood pressure, and usually that amount is 20 mLs per kilogram for adults. In the field, I get it. We open the bag up, but per curriculum and per testing, 20 mLs per kilogram. And you guys will hate me when we start to get into med math and pharmacology and drips. That's the point where everybody starts freaking out a little bit. But I promise it's not that bad. Two major classes of sedation medications. So we have analgesics and we have sedatives or hypnotics. So a good example of an analgesic is morphine. Fentanyl is another example of an analgesic. Those are going to be more your pain medications, decrease the perception of pain. As to where a sedative would be something like Versed, Valium, Ativan, medications that we can use to, calm somebody down during an anxiety attack or calm them down, whatever might be going on at the time. As to where hypnotic is literally kind of making them high almost a little bit. That's ketamine, that's etomidate. They're totally different classification of medications. But the big two that we're going to mainly deal with are going to be etomidate and ketamine. So the two medications they talk about when we refer to benzos are diazepam and midazolam. Anything that usually ends in AM is a benzo. So there's a third one in there as well. You have diazepam, you have midazolam, and you have lorazepam. So diazepam is Valium, midazolam is Versed, and lorazepam is Ativan. And those are the big three when we talk about benzos. You might see some patients that are on something called like alprazolam. It's a prescribed medication for anxiety or ADHD or whatever it might be to calm them down a little bit. That's a pretty commonly prescribed medication. But again, it ends in the AM. It's probably going to be a benzo. Now, some side effects of benzos. You can see decreased respiratory drive and you can see hypotension. That's why our dosage changes depending on what we're going to do it for. Somebody having a seizure, I'm not going to use as high a dose as I would for somebody that I'm going to intubate because I want to keep that person having a seizure's airway open. The person I'm going to intubate, not as big of a deal because I'm going to take their airway from them. But that's where you'll see two different dosage classifications. There you go, side effects. Respiratory depression, slight hypotension. Now, there is a reversal drug if you overdose somebody on a benzo. I don't know of anybody that carries it. I used to know one service, but they don't even carry it anymore. It is what's called flumazenil, or the other name for it is romazicon, Romazicon. Romazicon came in kind of a weird dose. It was like 0.2, 0.3, then 0.5 that you had to give the patient in a 3-dose series. Again, I don't know anybody that carries this anymore. It's just not a drug that we commonly give. If you overdose somebody on benzo, the best advice that I was always given was, hey, maintain their blood pressure and just bag them till they start to come out of it. We have what's called dissociatives. And so what dissociatives' job is to do is essentially distort the patient's senses. This could be sight, this could be sound. It'll essentially dissociate the patient from what's going on and dissociate them from themselves. Almost like you're disconnecting their mind and their body. It puts them into like almost a state of anesthesia. If any of you have had any sort of surgery or anything like that, and they ask you to count backwards from 100, you get to like 97 and you're out. You're usually not out at 97. You probably still counted down to like 85 or something like that. You just don't remember it because of amnesia, and your body quit remembering at a point due to that anesthetic effect. One that we're used to dealing with, or you probably heard of, is ketamine. You know, when I was going to paramedic school, we weren't even taught ketamine. Ketamine wasn't a thing that we gave at the time. Um, you know, in the last 5 to 7 years, I'd say roughly, ketamine has really been reintroduced to EMS in regards to it's great for pain management because you have the potential for respiratory depression if you overdose them and the potential for hypotension, but it's generally not as great as it would be with some other medications. So generally you won't knock out the respiratory drive unless you severely overdose these patients. We have opioids. We should all be familiar with opioids. Two most common ones that we'll deal with, actually one most common I'll say is fentanyl. Um, Morphine itself is also a derivative of like it's a synthetic version, as where fentanyl is like plant derivative. So our concern with this, and we've all heard of opioid overdoses, we know what Narcan is for, is that our patients will become unresponsive, they will lose their respiratory drive, and you can potentially see a drop in blood pressure. Any sort of medication that causes relaxation, whether it be a sedative, whether it be a seizure medication, anxiety medication, any of these can potentially drop your blood pressure because it's calming you down. You know, we have two different systems within our body. We have our sympathetic system and our parasympathetic system, our fight or flight system, or our rest and digest. One's going to cause an increase in heart rate, one's going to slow our heart rate down. That's what they're referring to when they say central nervous system. So that if I take too much of fentanyl or morphine, what happens is that my parasympathetic system, my rest and digest system, takes over. My body starts slowing down, it starts shutting down a little bit, my respirations go down until the point that my body can no longer maintain it. Now, how do we overcome that? We use Narcan, we use naloxone. Problem is, depending on if it's like a medical grade opioid or one that's been cut with something else, it was recently that we've seen patients getting between 8-12 milligrams of Narcan before we start to get a response from them. Accommodate, very common for RSI procedures. It's a hypnotic, goes by the other name of amidate. Generally, when we're going to give medication, like I know my protocol states, okay, you give fentanyl to kind of ease the pain, take the edge off. Then I give Versed to sedate them. Then I give etomidate or ketamine to kind of dissociate or hypnotize them. And then I give a paralytic to paralyze them. They go in that exact order. I can't give the paralytic first because and please remember this throughout your whole paramedic career. Giving a paralytic first, a paralyzing agent, the patient is still going to feel pain. They just can't respond to it. I've seen it accidentally given before any other drugs, and you can literally watch that patient cry, but yet their eyelashes don't move, their eyes don't move, nothing. But you can literally watch them tear up because they're in pain. They can't talk, they can't do anything. Again, a lot of these we're going to talk a little bit more about when we get to pharmacology, and it is on your drug cards, which I have listed on Canvas, your drug card sheet. So make sure that you're making a drug card that is listed on Canvas on that Word document on what I want on your cards. If I have a student send me a good example of them and they're okay with sharing it, then I might do that just so you guys can see how they should look. You literally just go buy some index cards and write on them or type them out, whatever's easiest for you, but in a place to where you can readily access them. When we start to talk about neuromuscular blocking agents, that is what a paralytic is. It blocks neuromuscular function. It doesn't allow, how do I say this? It doesn't allow impulses to travel from my brain to my body. So that if I say, okay, I want to grab a glass of water, I have an impulse to say, okay, water, grab, my arm will then move to grab it. In a neuromuscular blocking agent or paralytic, I might be thinking it, my body won't react to it. I might tell my body to do it, it won't react to it. Because we have essentially put a roadblock in a highway and it's not allowing those impulses to get through. They'll a lot of times say that with neuromuscular blocking agents, um, some you can see the patient's eyelashes start to flicker. It's what's called fasciculations. And then when the flickering stops, is a good indicator that your patient's paralyzed. Because what a neuromuscular blocking agent or depolarizing agent is what we call it. There's depolarizing and non-depolarizing. Depolarizing makes your muscles work as hard as they can and tires them out and just doesn't let them build energy back up. Non-depolarizing just is again that block in the highway, just doesn't allow your impulses to get through. So that's why when you see those eyelashes flicker back and forth and then stop, it's the body isn't letting your muscles reset, so it's paralyzing it. Again, patients can be conscious, just paralyzed. That's why we don't push paralytics first. If you're going to give a paralytic, you better be damn sure that you know how to manage this patient's airway or have a primary and a backup. I'm not going to cover this because I don't feel until we get up to this will be explaining pharmacology and it'll make a little bit more sense than not in airway. It won't, you guys will get freaked out a little bit. Some of the common paralytics that we deal with. Succinylcholine is a depolarizing. So it makes all the muscles twitch. It takes energy. It can take oxygen until it doesn't let them reset. As to where like vecuronium, pancuronium, and rocuronium are non-depolarizing. They just don't let the impulse happen. A good example would be, okay, again, I'm sitting at my desk. There's a glass of water in front of me. Succinylcholine, let's say I inject myself with that, and it's trying to stop my body from grabbing that glass of water. So if it, I don't know, makes me get up and do like 50 sit-ups, 50 push-ups, ton of jumping jacks, and I sit back down and I'm just like, man, I am exhausted. Like I'm too tired to reach that bottle of water. That's what depolarizing is. It's exhausted all the energy and I have none left to act to anything. Non-depolarizing is just, hey, I'm gonna grab that cup of water, but my body isn't responding to it.
Is there a benefit for one over the other?
Um, I wouldn't say a benefit. Some have like rocuronium and pancreas. The non-depolarizing have less complications or side effects. You can use them in patients a little more freely, but the problem is, um, like succinylcholine will last maybe 1 to 5 minutes of paralyzation, as to where the other three can last up to an hour of paralyzation. And some facilities don't like them when you bring a patient in that's paralyzed because they can't assess the patient at that point. They have to wait till the medication is worn off. If you have a long transport time, obviously I'd go with one that's going to take a little bit more time. If you have a short transport time, that's where you see more sucks used. But sucks has some contraindications, like possible brain swelling. You can't use sucks. Well, that kind of makes me nervous because in a patient that has a severe brain injury and I want to intubate, but what do? Do I risk the brain swelling or do I let this patient die of starvation of oxygen? Another thing is since succinylcholine depolarizes, expends all the energy out of our muscles, there's studies that show that our patients will become more hypoxic by using sucks because we've exhausted oxygen to cause the muscles to twitch. But it really just depends on the situation. My services, all of them carry rock. Again, it has a lot longer onset time or duration of 30 to 60 minutes, but it's a lot safer in terms of paralytics. And here's the thing is 30 to 60 minutes, I have to maintain that airway for 30 to 60 minutes. As to where sucks, if I fail, I might just have to bag that patient for 1 to 5 minutes until the paralytic wears off. Now, we generally don't redose paralytics. You can, absolutely you can. if you need to reparalyze the patient, but generally we don't. It's just a one-time thing. It's just to get them intubated, and then we keep them down with a medication such as Versed to keep them sedated. There you go. Fasciculations can be observed during this administration of sucks because we see the eyelashes flicker back and forth, and then when they stop, that's how we know that we're probably paralyzed at that point. Depolarizing, again, very rapid onset, short duration. As to where non-depolarizing are going to be a longer, the onset isn't much different, but a longer duration. I'd say the most common ones you're going to use, so you're going to see pancuronium. I'll be honest, I've never seen. I do know some services carry it, but um, I've used succinylcholine, I've used vecuronium or vec, and rocuronium or rock. So the three that I use were sucks, vec, and rock. Those medications also do have to be refrigerated. They have to be kept at a certain room temperature. So that's why a lot of services that carry them have a fridge, either built into their ambulance or like a mini fridge somewhere in their ambulance that those drugs are stored in. And paralytics are not considered a controlled substance, believe it or not. They're not like narcotics, which terrifies me a little bit, but they're not. All right. Before I jump into RSI, I'm going to give you, we're over halfway through the slideshow. I'm going to give you guys 10 minutes. 6:52 would be 10 minutes. We'll come back here. I'm guessing by 7:30 we'll be on with the slideshow and I can kind of answer any questions you guys have and I'll explain our test and everything. So take 10 minutes, grab a drink, grab something to eat if you need to, if you missed dinner or whatever, getting in class, and then we'll be back here in 10 minutes. All right. So RSI, I know you guys all probably know what RSI is. Using medications to essentially put somebody, I hate to say the word down, but to put somebody down to sedate them to the point that you can intubate them pretty quickly. It's not just sedating them, but also paralyzing them. If we're doing simply just sedation and we're able to intubate them, we call that medication assisted. If we have to use a paralytic, we call it rapid sequence because there's a certain sequence of events that have to take place, certain sequence of medications that have to take place before we can intubate the patient. A lot of patients you can get, I know like my protocol state, after I give Versed or Etomidate or whatever it is, that I can try the intubation. If it works, the patient doesn't have a gag reflex, great. I don't need to use a paralytic. And I would just keep them down with Versed or whatever. Sometimes in those patients, though, if they have laryngospasms or spasming of their airway or gag reflex, then yeah, I would end up using the paralytic. But you don't always have to. It depends on the patient. It depends on your protocols. If you have a patient that is conscious, that you have to RSI, you need to tell them what you're going to do. Unless they're like going downhill fast, losing responsiveness, losing consciousness, that's a totally different story. But in the event that you have a patient that's conscious, maybe they're just struggling to breathe really bad, a key indicator is the patient telling you, they're getting really tired, then yeah, explaining to them is pretty important because again, if they're conscious and able to make their own decisions, they can technically refuse to allow you to intubate them. I had a patient like that one time that did not want to be intubated, and we just literally had to manage him on the way to the hospital. Pre-oxygenation is literally what it sounds like. Prior to performing intubation, we'll use either high flow O2 via like a non-rebreather mask if they're breathing. If they're not, we might use like a BVM hooked to oxygen, and we're literally trying to get their oxygen saturation up just enough to where we feel confident in performing the intubation. Now, does that always work? No, because sometimes we're intubating because of low oxygen saturation. But you'll oftentimes, if you've been part of an intubation before, they'll call it bagging the patient up. They have somebody literally pre-oxygenate, get the patient ready. They'll sit there and bag them for a little bit while you're getting your equipment ready. At the point that you are ready, you'll let them know. They will then remove the bag and you'll perform the intubation. In the event that you suspect your patient will go bradycardic, and this is mainly for peds. A lot of times in pediatric population, we're worried about bradycardia uh, due to the gag reflex. They can give something to speed up their heart. Atropine is a drug that is used to treat bradycardia, so it works by speeding up your heart. So sometimes they will pre-medicate with atropine in because they're anticipating that the patient is going to brady down a little bit. As soon as you get your patient sedated, and again, your protocol could be as simple as Versed, um, fentanyl, etomidate, and then a paralytic. Or it could just be like Versed and a paralytic, or it could be etomidate and a paralytic. It's really all depending on what's in your protocols. But as soon as the patient is sedated, then we administer the paralytic. Again, we never give the paralytic first. Generally, the onset of the paralytic will be within 1 to 3 minutes, I'd say. Oh, it says 2 minutes right there. 1 to 3 minutes roughly before we start to see that patient either become totally paralyzed or we realize that the medication isn't working. Some of the things we look for, well, if our patient wasn't breathing before, they're probably still not breathing. But if there was somebody who was breathing on their own and you see a period of apnea, that's a pretty good indicator the patient is paralyzed. The mandible will actually start to relax, so we won't see that locked jaw. And then again, the eyelash reflex. So a lot of times what you'll see, somebody will run their finger over a patient's eyelashes to see if they twitch. If they don't, that's a really good indicator that your patient is paralyzed. Now, the intubation is probably the easiest part of RSI. I mean, the procedure of literally passing the tube through is not anything too terrifying. Something you'll also see is them maybe put like a nasal cannula in the patient's nose, even though they're not breathing, they're trying to get them some oxygen before they perform the intubation. But again, I rely off of end tidal as well. So if I get this patient intubated, end tidal is really high, I know that I need to bag them a little bit faster, knock that end tidal down. As to where if end tidal is really slow, then I need to probably, or really low, then I probably need to slow down my breaths. And this is something we are covering in lab this week. So once you get the tube into the trachea, once I get that tube right past the vocal cords to where I can't see that cuff anymore, then I'm going to inflate my cuff. I'm going to verify where I'm at the teeth marking. 19 at the teeth, 20 at the teeth, 18 at the teeth. And then I'm verifying placement at that point. I'm listening to the stomach, listening to the lung sounds, using end tidal to determine if I have proper placement. And again, if I'm looking at the graph with end tidal, I will see normal waveform. I will see those nice squares that I'm looking for. If I don't, then I'm potentially not in the right area. Now, I talked a little bit about earlier if I need to re-administer a paralytic after I intubate a patient. Not common, but there are some instances where you might need to, such as patient's gag reflex is coming back and they're starting to gag even though they're sedated, or the patient's starting to have severe muscle spasms, something like that. We might need to reconsider a second dose of a paralytic at that point. Some protocols will say unless they can get their patient's oxygen saturation status up, they generally won't intubate them. Just because, again, it could take a little bit of time to get all this secured, and your patient can obviously become hypoxic in that period, in that point. Now, depending on what medications you have and what medications you use is primarily going to be based on your assessment of the patient. If I have a patient with really low blood pressure, I might opt not to use a drug such as Versed that's going to drop their blood pressure during intubation. I might pick something such as etomidate or ketamine that's not going to have such severe side effects. And then having our backups ready. This is something we should all be. Does anybody's service not carry King LTs anymore by chance?
We don't carry them in Bondurant.
Okay. What do you guys carry iGels?
Yeah, just iGel.
Okay, I was trying to remember. I knew Chief Morris said we talked about that at one point. I can remember. We still carry Kings. I truly do like the King. It's very much a derivative of the old combi tubes that we had back in the day. They're blind insertion, obviously a really good backup airway if things go south. There are 3 different sizes. There's size 3, 4, and 5. Size 3 is generally made for anybody 4 feet and above, or 4 feet to 5 feet. Size 4 is 5 to 6. Size 5 is 6 feet and above. The issue that some people see with them is they can kink really easily. I can't say I have had one kink because here's the thing: is an ET tube can technically kink. They're all soft rubber, but I can see there potentially is that potential for them, depending on the position that the airway is in of the patient. Looks very much like this when it's inserted. And you guys inserted King supraglottic airways for your one of your competencies, as opposed to our combi tubes, which you might see in here is referred to as a dual lumen airway. Those had 2 tubes off the top of them. They had 2 cuffs. So we would inflate one and inflate the other. One of them went to the stomach and one of them went to the trachea. So if we ventilated on one tube and the stomach was rising, we then switched to the other tube when we knew that was in the trachea. It was kind of a cool concept back in the day. 2 different Kings. There's the King LTD, the King LT's SD. Now, LTD is primarily for adults and children, can be used in either discipline. The LTSD is for adults entirely. Now, the D at the end of King LT stands for disposable, if that were to ever come up. You can use a bougie if needed, but again, they're blind insertion. I'm not going to cover all the different parts of a King. You guys should be familiar with those. Again, if I can't get an intubation, I go right to a king. There's no sense in me letting ego and pride get in the way of patient care to where I say, oh, I've got to get this intubation. No, just fall back to something simple. We're gonna skip over to the LMA. These had a brief stint where everybody in the EMS thought they were the greatest thing in the world. Again, blind insertion. It just doesn't have that cuffed balloon. The only thing that you're inserting air into is essentially what looks like a small mouthpiece, which fits right over the tracheal opening. So when they were inserted, let's see if I can draw it right here. This is your inflated part. So literally it would stop the stomach, anything coming up this direction, and would introduce air down to the lungs via this direction. I don't know a whole lot of people that carry LMAs, and that's not saying any of you don't. I just personally don't know anybody that carries LMAs anymore. Seems like everybody's still sticking with either Kings or switching to iGels. One of the complications though with LMAs is that again it has that really soft balloon at the end, kind of like you see with a BVM mask, that can fail at some point. Any balloon can fail. Any of our equipment can fail, and also you're not going to get an entirely good seal over the trachea. So you will get some air leaking down to the stomach, which is going to cause gastric upset, cause the patient to vomit. Where we see LMAs primarily used now, I'd say, is during surgeries, same day surgeries. They use LMAs a lot, but again, that's in a clinical setting where they have a lot more stability of the patients. They're not concerned about airway management because they can manage the airway pretty quickly if things go south. The LMA, though, something kind of neat, and I only learned this probably within the last year, is that a 6 millimeter tube or smaller can actually fit down this opening of the LMA. If the patient is going downhill and the LMA is properly placed, you can insert an ET tube down that tube if need be, which is kind of cool. Different varieties. This one on the bottom left here, which I'll label 2. This top part looks very similar to our iGels, which we have now. This is more of the standard LMA that I'm used to. It does have an option here. It has 2 ports. This one is obviously for the bag to attach to. And then you've got this secondary port here that you can suction through if needed. Again, iGels are blind insertion. The bottom of them is very, I don't even know how to describe it, gel-like, I guess. The main thing was it is with it is that they were really soft at the end. So even if you were to push it too hard or something like that, it's not going to create severe trauma to the patient's airway. A big issue with iGels, though, is that they rely off of body heat to seal. That bottom of that mask relies off of body heat. So if you have a patient in cardiac arrest that doesn't have that body heat, or somebody that's maybe in hypothermia or something, that iGel might not seal the best. In the OR setting, they use iGels pretty frequently. There is a channel, like a little tube right next to it, again, where you can pass either a gastric tube or you can insert suction through that if need be as well. They're very similar to, I mean, as far as how Kings go in, LMAs and iGels, they're all very similar. Again, it's blocking the esophageal opening and it's introducing air into the tracheal opening. I wouldn't think you're going to get quiz on anything iGel related because not everybody in the US has the ability to use iGels. Are multi-lumen, dual lumen, combi tubes. Like I said, they were inserted blindly. They had 2 different cuffs. They had 2 different ports. One went to the esophagus. One went to the trachea. Let's see if we can get a picture here. Right here. So I've got port 1 for my BVM, and I've got port 2 for my BVM. So once it was inserted, one side literally, one went into the trachea, one went into the esophagus. So if I accidentally put this in the esophagus, as you can see in figure 1 here, I could then switch to my other top and I would be able to breathe through the trachea because that's what all these little holes are for on the tube itself. As to where on the right, if I went into the trachea, great. I've got good position, no issue, but I still could introduce into the stomach at that point, unfortunately. I don't know anybody that carries combi tubes anymore. They went by the wayside. It seemed like 10 years ago almost. I wouldn't even say that when we talk about like multi-lumen airways, I wouldn't even say that these are our only indications. Um, there's so many instances where we can use a king, we can use an IJO, we can use an LMA, but and it seemed like 10, 12 years ago we did a lot more, but now we're so focused on proper airway management and performing an intubation and total isolation of the airway. You know, in the instance the patient doesn't have gag reflex and is unresponsive, even as a basic, you could insert a king. The only problem is if that patient starts to come to, you have no way to sedate them, was the big thing behind it. Now, let me ask you guys this. It says one of the contraindications is a history of alcoholism. Why would that be? Anybody have any guesses?
Esophageal
Esophageal
varices.
varices.
Bingo. But esophageal varices. So somebody explain what that is, if you know.
It's thrown up a lot. Scar tissue, spasms inside. You can bleed out through the airway or the
Okay.
esophagus.
Yeah, so what happens is in cases of extreme alcoholism, the liver hardens, right? We get cirrhosis of the liver. Well, after a period of time, the liver can't filter like it should. So that blood starts to back up somewhere. And a lot of times it starts to back up in the vessels around the trachea. Well, what happens is those walls start to become weakened over time and they can actually burst. So a problem when we're using an airway that could potentially cause trauma is that we're going to cause any sort of bursting like that. And we're going to see the patient start to bleed out. So anytime you see a history of chronic alcoholism or a history of alcoholism and the patient's throwing up blood, we should automatically assume esophageal varices. And at that point, start thinking further down the line as far as hardening of the liver. I'm not going to cover this too much of multi-lumens, but some of the advantages again is if I of that like combi tube, if I inserted it in the esophagus, I had another tube that I could go back and ventilate through the trachea. There wasn't really a whole lot of manipulation that's needed of the airway, like tilting the head back or anything like that to insert them. Again, since they were blind insertion, they were very thin. They were almost like the width of an ET tube, as opposed to like our King LTs or iGels and our LMAs, where they're a little bit thicker. Now, some of the things we were seeing go wrong. They are temporary. We can't keep a patient sedated, especially if the patient starts to wake up. There is a risk of aspiration. So if they start to have any sort of gastric upset and that starts to go down into their lungs, we've got a problem. We're going to jump right to crikes. All right, so surgical and non-surgical crikes. Surgical is using a scalpel or some sort of sharp-edged device to create an opening in our cricothyroid membrane, right here, that small little spot, to where we can ventilate the patient. Everybody's big concern is there a chance I'm going to hit their jugular vein or something like that, or a carotid artery or whatever it is. I mean, the arteries run pretty far away on either side of the neck. I mean, if you're overcutting that far, you're probably going to hit an artery. But right down the center, no matter what tissue it is, if we create an opening, we keep creating an incision, we are going to see bleeding. We're going to see capillary bleeding no matter what. But surgical is using a bladed edge. Non-surgical is like a needle or a quick crike. This is technically an open crike is a quick crike, but if you look at the tip of this, the reason they call it an open crike is because that tip is sharp. I mean, it's sharp. Like honestly, if I open the package, I could probably slice my finger with it. Um, so they still consider it an open, but here in the state of Iowa, we are allowed to do quick crikes as paramedics. We just cannot use a scalpel to create the opening. We have to use a quick crike or a needle crike. But that's an example of a quick crike, and that's something again that we'll cover during skills lab at some point, probably more towards our trauma and airway management in regards to trauma. Now, what are the indications that I'm going to use a crike on somebody? Severe facial trauma, severe airway trauma. If there's any sort of obstructions in the airway to where I cannot manage the airway effectively, patient has an inability to open their mouth, and I need to get them airway quickly, then yeah, unfortunately, I can't use the face. I'm going to turn to the neck. If I need to create that opening, it is a bad day. There's a lot of things happening at this point to where we are literally having to create a new opening in somebody's windpipe. It's not good by any means. It's not something we do very often. It's not something we are 100% proficient in, but we should know the anatomical landmarks and what we are looking for, because in the instance you need it, you need it. There's no time to mess around. If you need to do a quick crike or a needle crike, then you need to do it at that time. Now, some of the contraindications, though, if you can support a patent airway a different way. If I can intubate this patient, there's no need I need to do a crike. Inability to identify anatomic landmarks. So if you aren't confident and you're not 100% sure what you're looking for, then you really shouldn't be doing it. Any sort of crushing injury, say this is a car accident, patient hits their neck on the steering wheel. Okay, could be a problem because we have instability of the trachea at that point. And young peds, because their airways aren't fully developed, we won't be able to identify the landmarks in them. They don't have those cricoid rings in our trachea like we do as adults. It's supposed to be able to be performed quickly, but it takes a little bit more time because we have to get our nerve up to do it. It doesn't, you do not have to manipulate the spine. It's a lot easier if you can. If you can tilt that patient's head back to where you can really see their trachea protruding a little bit, it's going to help you a lot, because everything we're trying to find is based off of feel. Nothing is off sight. You're feeling for your cricoid membrane, you're feeling for your thyroid, you're feeling in between those, almost like a little valley for that soft, spongy spot. It's a spot you push on your own neck and you start to like gag a little bit. That's your cricothyroid membrane. And it's a very tiny, very small spot. And even in skills labs, try to find that spot on one of your classmates. It feels weird. I know it's weird touching each other, but try to find that spot on your classmates. If somebody has a short, fat neck, good luck. You really want people that have like almost like a giraffe neck before you're performing a crike on them, because again, you want a workspace and you want to be able to effectively feel the anatomy. If there's a lot of baby fat or a lot of just fat in general underneath somebody's chin, it's gonna be really difficult for you to be able to feel the anatomy and what you're shooting for. The reason they say an open crike is a lot more difficult than a needle crike is because a needle crike is a very small needle. I wouldn't say small needle, but it's smaller than a scalpel. It's smaller than a quick crike. So it's a lot easier for me to put that small object into the small opening, as opposed to putting a larger object into a larger opening. Somebody had asked me, last year, a couple years, or one of the CCP programs, if I push the needle too far, is there a potential I can go back through the back of the trachea? And that was a valid question. I didn't honestly know the answer to it. And I consulted with our medical director, who's Dr. Poole in the ER at Mercy. And he said the back of the trachea is actually super tough, almost like bone. He goes, it'd be almost impossible for you to penetrate through the back of it. Again, if we don't have a quick crike, then we're using a scalpel, we're using an ET tube, and we're using tape. Those are the big things that we need. Hemostats, maybe, or like forceps. And that's really just to open up the incision once we make it. I mean, if you let it close, it's gonna heal up very quickly. So once we get it marked open, or it open at least, we'll put forceps in there to kind of spread it open like pliers and hold it in that position. That way we can put our ET tube through. And again, you guys will have a chance not to practice surgical crikes, but to practice needle crikes, and then we'll kind of show you as far as surgical what equipment is needed and how that is performed. But usually that's covered in CCP class in the state of Iowa. Needle crikes, all too often, it's often asked is, how do you breathe for somebody through a small needle or through a small catheter? And I'd mentioned this translaryngeal catheter ventilation device. Sometimes they're called like transjet ventilators. This will literally hook onto your tube top. So a 3.5 millimeter, 3.0 millimeter tube top will fit inside an IV catheter. So that's what we use to connect to the IV catheter once we do a needle crike. And then generally use a device like this, where his finger is a trigger. So when it's time to respirate or breathe for the patient, he squeezes that trigger and it sends a short burst of air, a very high PSI burst of air to overcome the diameter of the needle. And that's how they're able to breathe for the patient. I mean, sure, you could sit there and bag them. It's just not going to be effective. It's going to kind of suck a little bit, to be honest. If you don't have that translaryngeal jet ventilation device, I'd rethink why there's needles instead of a quick crack on the ambulance. Big indications for me: inability to maintain an airway any other way, severe facial or airway trauma, severe obstruction that I cannot clear. Trying to think what else. Let's see. That's about it. Or uncontrolled oral bleeding, because they're saying that you're not gonna be able to find your structures at that point. Now, that transjet ventilator device, though, can be kind of harmful in patients, especially if this is a trauma and maybe the patient has a potential for having a pneumothorax. Yeah, I'm a little more concerned at that point with doing this because I'm introducing a crap ton of pressure in the chest. And remember, the more pressure I introduce into the chest, the more the blood pressure can drop. So especially with patients that have or are borderline hypotensive, I got to be really careful how much air I'm introducing to their chest, because that's pushing on their blood vessels and not allowing blood to return back into their heart. If possible, if you're going to do this, a 14 gauge is the most often thing we should do. I wouldn't say most desirable. That's what I'm going for. Most desirable size we should use, because the smaller the number in regards to IV catheters, the larger bore we have. So a 24 gauge needle is really small. I swear a 14 is really big. Some places even carry 10 gauges for needle crikes or needle decompressions. 10 ml syringe, and why that's important is you can actually put the syringe on the back of the needle. Gives you something to hold on to instead of just using the needle itself. Some sort of oxygen device, absolutely. And then a means to breathe for the patient, whether it be that jet ventilator device or just a BVM in general. And that ends your first chapter for all of paramedic school, chapter 15. So let me get your screen pulled back up here. All right, questions, comments, concerns about this chapter? You're gonna have to review it. I'm giving you literally a week to review it before your test. Your test is not due till midnight next week. My test actually opened today. So you can access the test from between now and next Tuesday, or next Tuesday, to take your test anytime. It is 50 questions, worth 50 points. So take your time on it. Give yourself, don't take it when you're on shift and you have to run away on a call. Take it when you're at home and you can actually put some time towards it. You get to use your book. You get to use your notes. Watch my recordings if you need to, if that helps you out a little bit. Look at the PowerPoint. You have the means to look up any resource necessary when taking these exams. And if you notice on the schedule, I don't have anything planned for next week. So if between now and next week you do not have time to do anything, literally class time next week is reserved for nothing but the exam. We're not covering a new chapter. We're not covering new curriculum. It is just for the exam. So I prefer it that you take it during that time because that's what's slotted for you. You technically can access it early, but there's no PowerPoint or anything that we are going over next week. I'll be on here available for questions. You guys will log in as well. I just won't be giving any sort of curriculum or PowerPoint or anything like that. I'll just simply be there to answer questions if you guys have them. Does that make sense?
So if we have for Tuesday, we don't have to log in at all?
If you get it done before Tuesday, is that what you're saying?
Yes.
Technically, no. So if you get it done before Tuesday, I'm not holding that against you, and technically, no, there would be no class for you next Tuesday then. Which, I mean, if somebody wants to do that and you have the time to do that, great. You essentially get a free night off. It's built into the schedule that way on purpose. But again, that's up to you. Some people like having the time during class to do it. Some people would rather get it done before and have the night free. Either way, you're gonna have free time. But I know how rough school can be. I know that time is something that is very valuable, so I try to slot that time for you guys. All right, questions about anything?
With our labs on Saturday, is it a must that we wear our